الليل إذا سجى ما ودعك ربك وما قلى وللآخرة خير لك من الأولى ولسوف يعطيك ربك فترضى ألم يجدك يتيما فآوى ووجدك ضالا فهدى ووجدك عائلا فأغنى فأما اليتيم فلا تقهر وأما السائل فلا تنهر وأما بنعمة ربك فحدث.
Good morning and Assalamu alaikum. My name is Aziza Ahmed. I'm a fourth-year medical student from Rasheed Medical College.
And my name is Muhammad Ali, and I'm a first-year medical student from Central Park Medical College, Lahore.
We welcome you all to the 28th Annual International PSR Conference, proudly organized by the Pakistan Society for Rheumatology. We are delighted to commence the first session of the conference, the PSR Review course. The session will feature talks on topics that are highly relevant to rheumatological practice and will provide a comprehensive overview for both clinicians and trainees.
Before we begin, a few housekeeping points. The rules of the house and other important announcements are being displayed on the screen for your reference. A Q&A session will follow the talks. However, due to time constraints, we will not be taking questions directly at the microphone. Instead, attendees are requested to obtain Q&A cards from the ushers, write concise and relevant questions, and pass them on to the chairs through the ushers. We thank you for your cooperation.
Let's begin. We take great pleasure in welcoming the chairpersons of our session. The chair of the session, Dr. Tahira Parveen, Head and Assistant Professor, Department of Rheumatology at Liaquat National Hospital, Karachi, and Dr. Ataur Rahman, a practicing rheumatologist currently based in Faisalabad, as co-chair of the session. May I now request our respected chairs to please join us on stage.
We begin this exciting journey with our very first distinguished speaker, Professor Uzma Rasheed, Head of Department of Rheumatology at PIMS Shaheed Zulfikar Ali Bhutto Medical University, Islamabad, Pakistan. To inaugurate today's scientific discourse, Professor Rasheed will be delivering a talk on myositis, new classifications, biomarkers, and emerging therapies, highlighting the latest developments and breakthroughs shaping the evolving area of rheumatology. Please join me in giving a very warm welcome to Professor Uzma Rasheed.
Thank you so much. It's a pleasure to be here, and I would like to thank the organizers for this opportunity. It's a privilege to be speaking at the biggest rheumatology event of the Pakistan, and I would also like to extend my sincere congratulations to the organizing committee for making this, putting together this remarkable conference. So before I proceed to my talk, I would request you to please switch on your internet so that you can participate in the quiz during the session. So myositis is a rare disease, but our curiosity isn't. So let's delve into this muscular disease group, which keep on challenging us both diagnostically and therapeutically. So what are the idiopathic inflammatory myositis? They are a group of rare autoimmune diseases with a broad spectrum of clinical manifestation that share a common features of immune-mediated muscle injury. I'll be covering the topic under these headings: classification, biomarkers, and emerging therapies. So classification of myositis is a source of great debate because of the increased recognition of its subtype. Much progress has been made since the Bohan and Peter classification criteria in 1975. These criteria overdiagnosed polymyositis because of the initial difficulties in differentiating polymyositis from the conditions like muscular dystrophy and inclusion body myositis. So it classified the myositis into 6 different categories. Later on, with the increased recognition of histopathological changes, NMEC classification criteria classified the myositis into 7 different categories. And later, Trevano et al. Proposed a separate classification of overlap myositis. Now coming to the latest classification criteria, that is 2017 EULAR ACR classification criteria, that is the first data-driven classification criteria. It was partially validated at the time of its publication. This classification criteria, in this classification criteria, 16 variables from 6 different categories, they were assigned weighted score, and at the end, the probability of inflammatory myositis is calculated. If the probability is less than 50%, it rules out inflammatory myositis. After the patients have been classified as having inflammatory myositis, based on this classification tree, they are further subdivided into 6 different categories, including polymyositis, inclusion body myositis, amyopathic dermatomyositis, dermatomyositis, other juvenile myositis, and juvenile dermatomyositis. But there were, excuse me for my bad throat, I am under the weather. So there were limitation of this ACR EULAR classification criteria because it only included anti-Jovan antibodies and other antibodies were not taken into account. Myositis-associated antibodies and features of scleroderma, interstitial lung disease were not included in these criteria. These criteria mainly focused on the cutaneous and muscular manifestations. Other organ manifestations like interstitial lung disease, like arthritis, Raynaud's, they were not taken into consideration. In addition to that, a big subcategory, that is immune-mediated necrotizing myopathy, was not contained as a separate classification criteria. So keeping in view these critical issues, a new interdisciplinary collaboration of the clinicians is revising 2017 classification criteria of ACR EULAR. And so the myositis classification is a work in progress. And keeping in view these evolving changes in myositis classification, the following subtypes are they're currently suggested. Pediatric, including juvenile dermatomyositis, other juvenile myositis, dermatomyositis, or clinically amyopathic dermatomyositis. Polymyositis, inclusion body myositis, antisynthetase syndrome, and overlap myositis, and non-specific myositis. For the sake of time, the juvenile myositis and inclusion body myositis is not included in this talk. So the other myositis, these are the other rare type of myositis which are also included in the classification. So now coming to this scenario, first scenario, this is a 55-year-old lady who had symptoms of inflammatory polyarthritis 6 months back. She had raised inflammatory markers and she had negative serology of RA effector and anti-CCP were negative. She was treated as a seronegative rheumatoid arthritis by the local doctor with leflunomide. Later, she developed fever, weakness and fatigue, and cough with scanty sputum along with dyspnea for last 1 month. For these complaints, she was admitted in pulmonology department. Her radiological investigations showed that she had ground glass opacification and the findings were consistent with non-specific interstitial pneumonitis. Her infection screen was negative. She had raised inflammatory markers and the initial workup showed ANA positivity in high titers. At that time, rheumatology department was taken on board and she was re-evaluated. She had a history of inflammatory polyarthritis with Raynaud's, but there were no other features of connective tissue disorder. Examination shows inflammation of the small joints of the hand and knees and crepitations till the mid-chest. Now her extended profile was ordered and this extended profile showed that she had anti-Rho antibody positive, anti-PL7 antibody was positive, but had normal muscle enzymes, EMG and NCS. So scan this QR code and submit your response. What is the likely diagnosis? So, yes, you're right. The diagnosis is anti-synthetase syndrome. So, ACR EULAR initiative class project. It aimed to develop and validate new ACR EULAR classification criteria. And this classification criteria based on the clinical domains and serological domains. And the score is calculated, and if the score is more than 5.5, this makes the definitive diagnosis of anti-synthetase syndrome. And a score of more than 5 is consistent with a probable anti-synthetase syndrome, and more than 4 is possible anti-synthetase syndrome. Now coming to the biomarkers. Before going on to the biomarkers, go through another scenario. This scenario relates to a 36-year-old lady who presents with cough and worsening dyspnea for last 1 month, so that she requires hospitalization. She has multiple cutaneous lesions, including periorbital rash, inverse cotton, nail fold infarct, and cutaneous ulcer. But there was no muscular weakness clinically, and there was no skin tightening. Her investigation shows mildly elevated CPK, raised LDH, and radiological evidence of non-specific interstitial pneumonitis with consolidation. Her antibody profile shows anti-MDA5 antibody positive. So putting all together, this makes a diagnosis of clinically amyopathic dermatomyositis with rapidly progressive ILD, which is related to anti-MDA5 positivity. Now scan the QR code and submit your response. Which of the following marker correlates with the ILD severity in this particular patient? Okay. Okay. The answer is ferritin. So we'll come to this later on. So there is another question. This is the last one. Which of the following cytokine activates the JAK-STAT pathway? Which of the following cytokine activates the JAK-STAT signaling pathway? TGF-beta, interferon, anti-TNF, or IL-17? Submit your responses. Yes, this time you are right. It's interferon. So biomarkers in idiopathic inflammatory myositis can be non-specific biomarkers. They can be myositis-associated and myositis-specific antibodies, and potential novel biomarkers. Non-specific biomarkers include CPK that correlates with the muscle injury and muscle inflammation. The other includes aldolase, which is useful when CPK is not elevated. Another biomarker is the KL6, which is a glycoprotein, and it is released from the surface of the lung epithelium, and it is raised in patients with interstitial lung disease associated with dermatomyositis. So ferritin is the acute phase reactant, and this biomarker correlates with the ILD severity in patients with anti-MDA5 antibody positive dermatomyositis associated ILD. Myositis specific and myositis associated antibodies are also serve as the prognostic and diagnostic biomarkers. Anti-Jovan antibody serve as a diagnostic biomarker because it is positive in anti-synthetase syndrome. Anti-MI2 antibodies, they are also serve as a prognostic biomarker because they shows the good response to therapy. Anti-MDA5 is also has prognostic significance because it is associated with rapidly progressive ILD, which is associated with the worst prognosis. Anti-TIF1 gamma and NXP2 antibody also have prognostic significance because they are associated with malignancy. Anti-SRP antibodies associated with the severe muscle damage, and other and anti-synthetase antibodies, they are associated with the diagnostic significance because they are associated with anti-synthetase syndrome. This is the list of potential novel biomarkers which have been proposed in idiopathic inflammatory myositis, but they are yet not available commercially. Interferons. Interferons are the cytokines that have various functions, and they perform their functions by binding to the cell surface receptor. As a result of which, there is activation of JAK-STAT pathway leading to the increased expression of interferon-inducible genes. And it has been seen that these interferon-inducible genes are upregulated in patients with dermatomyositis, and other interferon-inducible genes and proteins are also found to be upregulated in blood, in cutaneous lesions, and in muscle biopsies of the patients with dermatomyositis. Siglec-1 is the blood-based biomarker of the interferon signaling pathway, and it has been shown that they can serve as biomarker for monitoring the disease. They can serve for the patient stratification for targeted therapy like JAK inhibitors, and further studies are needed to investigate their potential prognostic significance. Estrogen receptor 1. In the pathogenesis of idiopathic inflammatory myositis, brain cells are T cells, but activated B cells also play a significant role. And it has been seen that patients respond differently to rituximab. This can be because of the estrogen receptor 1, which modulates the response of rituximab in patients with idiopathic inflammatory myositis, and these biomarker is upregulated in patients who are rituximab responders. In addition to the traditional B cell depletion caused by rituximab, there is another mechanism in patients with inflammatory myopathies by rituximab binding to the receptors and leading to the increased upregulation of estrogen receptor 1, as a result of which there is increased myocardial function, mitochondrial function, and decreased nuclear factor kappa B activation, in turn leading to decreased muscle damage and decreased inflammation and beneficial effect in myositis. This is another biomarker, interferon lambda 3, which has been found to have prognostic significance in patients with anti-MDA5 antibody positive dermatomyositis, ILD. And these levels are increased, the patient who have increased level of these biomarkers have worse prognosis in addition to the old age and low partial pressure of oxygen. PSTAT3 IL-17 pathway has also been found to be involved in the patients with dermatomyositis because higher level are associated with increased transaminases, increased myocardial enzyme and HAQ score, in addition to low MMT8 score. So this may be a potential target for dermatomyositis, and it can serve as a potential biomarker in patients with inflammatory myositis. Now, emerging therapies. This is the list of the molecules which have been studied in inflammatory myositis in last year. As we know, the Janus kinase plays an important role in signaling of the interferon, and interferon-inducible genes are upregulated in patients with inflammatory myositis. So many studies have focused on the efficacy of JAK inhibitors in patients with inflammatory myositis. This meta-analysis evaluated the therapeutic efficacy of JAK inhibitors in patients with inflammatory myositis. 7 publications were included in this meta-analysis, and it included 91 patients. The molecules studied were tofacitinib, ruxolitinib, and baricitinib. And it was seen that CDASI improvement, that is cutaneous dermatomyositis disease activity index, it improved in a pooled data. It improved by a score of 17. Further subgroup analysis shows that maximum improvement of CDASI was seen with ruxolitinib, followed by tofacitinib and baricitinib. Further analyzing, it was seen that when the patients were given JAK inhibitors in combination with other immunosuppressive agent, there was more improvement in CDASI as compared to when they were used alone. MMT score also improved in patients who were on JAK inhibitors, and survival rate was significantly higher in patients who were on JAK inhibitors as compared to the control group. And there was also substantial improvement in forced vital capacity in the patients who were on tofacitinib. This second study, this is a small case series, evaluated the efficacy of upadacitinib in refractory inflammatory myositis, and it included 10 patients. The important thing is that they were refractory to at least 4 immunosuppressants before giving upadacitinib, and 3 of them had already received tofacitinib before giving upadacitinib. This picture shows the improvement in the cutaneous disease activity. This is the pre-tofacitinib, this is post-tofacitinib, and this is post-upadacitinib. So an aggregate improvement in CDASI was seen. It was significant. It improved from 10.5 to 2.5. And the 5 patients who have respiratory symptom in the start, their respiratory status stabilized while receiving upadacitinib. So it was concluded that upadacitinib appears to be effective in targeting the cutaneous manifestation of dermatomyositis, but further studies are needed to validate its efficacy on a broader patient population scale. Abatacept has also been studied and in patients with antisynthetase syndrome associated ILD. This small case series included 8 patients, and in this the patients were given subcutaneous abatacept 250 milligram every other week, and these patients were evaluated, and it was seen that there was significant improvement in DLCO, in King's brief interstitial lung disease, and the steroid dose was decreased significantly and associated with the improvement in the HRCT finding. This was a preliminary study, and it showed that abatacept may be effective in this group of the patient. The other study by Rohit Agarwal, it is a double-blind randomized placebo-controlled trial, and it included the patients who were refractory inflammatory myopathies. Subcutaneous abatacept was given as compared to placebo, and 24-week period, double-blind period was followed by an open-label extension phase. The results of this study showed that proportion of the patient who achieved the improvement were similar in both the groups. But on subgroup analysis, it was seen that there was significant improvement in patients who were non-dermatomyositis subtypes. So non-dermatomyositis subtypes may have beneficial effect with abatacept. Belimumab was studied in patients with juvenile and adult dermatomyositis, and the METAX score, that was myositis intention to treat score, was calculated at baseline at each belimumab visit and 24-week follow-up. And it was seen that there was significant improvement in METAS in both the juvenile dermatomyositis and adult dermatomyositis. Now coming to the efgartigimod, that is an FcRn inhibitor, that is a neonatal Fc receptor. What is neonatal Fc receptor? This neonatal Fc receptor is a transmembrane receptor, and it plays an important role in the recycling of immunoglobulin, as a result of which their lifespan is increased. But what efgartigimod does, It blocks the FcRn inhibitor, and it lead to the increased catabolism and clearance of the immunoglobulin, as a result of which the autoantibodies clearance is increased. So in a small study, the efgartigimod was used in patients with immune-mediated necrotizing myopathy. They were given efgartigimod weekly for 4 weeks and then followed up. And it was shown that 4 out of 7 patients showed improvement. And other scores which showed improvement were CK and physician global assessment, and other parameters did not show significant improvement. Alkivia study was a double-blind, placebo-controlled study evaluating the efficacy of subcutaneous efgartigimod, and it was also a 24-week period which showed significant result, and improvement in total improvement score was significantly higher in efgartigimod as compared to the placebo. So last is the CAR-T therapy that has revolutionized the treatment of hematological malignancies but it has also been seen to have success in patients with systemic autoimmune rheumatic diseases like SLE, systemic sclerosis, and antisynthetase syndrome. 2 case studies have shown improvement in patients with refractory antisynthetase syndrome, and one of the studies showed improvement in patients with immune-mediated necrotizing myopathy. Another study showed allogenic CD19 were successfully treated a refractory patient of immune-mediated necrotizing myopathy, and a small case series by Muller et al. Showed improvement in 3 patients of refractory idiopathic inflammatory myopathy, achieving the ACR EULAR major clinical response. So these are the take-home messages. Thank you so much for lending me your ears and neurons, and I hope this journey sparked both understanding and curiosity. Thank you so much.
Thank you for your engaging presentation, Professor Rasheed. Before we begin with our next speaker, I would request Brigadier Professor Amir Fakhr to join us on stage as chair for the first session. Now, as we continue with our scientific proceedings, it's a pleasure to introduce Dr. Aflak Rasheed, Associate Professor of Rheumatology at Sheikh Zayed Hospital, Lahore, Pakistan. Dr. Rasheed is a dedicated clinician and educator, actively contributing to the advancement of rheumatology practice and research in Pakistan. Today, he will be sharing his insights on systemic sclerosis, new treatment strategies, and biomarker trends. Ladies and gentlemen, please join me in welcoming Dr. Aflak Rasheed.
Bismillahirrahmanirrahim and Assalamu alaikum everybody. It's been a great pleasure, and I would like to congratulate the President as well as the Society who has organized such a great event of more than 4 to 5 days here, and thank to the Scientific Committee for letting me invite on a topic which has been always very near to my heart. Important thing which we come to know this morning in the first talk is that we are in an era of innovations, and we know that the elderly rheumatologists know that what agony we used to face while treating this disease in the last decade even. After 2010, the second part of the millennium, it was a great revolution which has set in, and now it is being practiced clinically. So this is the place where I come from. It is Sheikh Zayed Postgraduate Medical Institute placed at the heart of Lahore. And today we are going to discuss the summary of the EULAR 2023 recommendations, updated in 2023, emerging novel therapies, the concept of CAR-T19, which just Dr. Uzma has discussed, future research and biomarker-driven therapies, and a brief of the end organ management. So anybody can answer this, which place is this where we can have a very challenging area to rule or run? कौन सी country है ये? Indonesia, very right. Why it is difficult? It has more than 17,000 islands, vast distances between Aceh province to Papua New Guinea. It is nearly 5,500 kilometers. There is a lack of infrastructures, lack of communication, and diverse ethnicity and culture. And Jakarta is sinking. And what they have planned is they are shifting the capital to Nusantara in Borneo Island, somewhere here. So they are changing. The world is changing. So as systemic sclerosis. It has a diverse pathophysiology, a different option for different organ involvement. New research has rapidly emerging with even a pre-disease or pre-disease managements or early disease managements. And paradigms of treatment are changing rapidly. So scleroderma to start with is divided into systemic sclerosis and localized scleroderma. Localized scleroderma being having morphia, a localized fibrosis, as well as linear scleroderma, or if it is on the face, just like a saber crossed and coup de saber. While the systemic sclerosis has two varieties, diffuse cutaneous scleroderma and limited cutaneous scleroderma, and we should identify that usually we confuse between this localized variety and limited cutaneous scleroderma. These are absolutely two different entities. And the conventional triad of an immune system activation leading to vasculopathy and fibrosis, which is triggered by certain external factors, environmental factors, including infections, exposures, then oxidative stress, and loss of tolerance. So I'm going to start with a very interesting case review being shared by Dr. Laura Ross, who is a senior research fellow at University of Melbourne, and she has shared it recently in the last month's EULAR. A 70-year-old ski as well as sea surfers went to Japan for skiing and found for the first time excessive fatigue during his skiing, as well as Raynaud's phenomena, and also puffy fingers, also weakness with raised CPK of 2500, and serology with ANA and anti-SCL was positive. His troponin was also very much raised and gave the suspicion that he also has a heart involvement relating to systemic sclerosis. Echo and ECG was done, but it was absolutely normal, but troponins remained high. So they went for cardiac MRI, and the cardiac MRI showed in the T1 and T2 sequences inflammation as well as fibrosis. So full throttle of treatment initially with rituximab and high dose of methylprednisolone was started, and after a while it was seen that his troponins were still raised. So she was shifted to cyclophosphamide therapy. Later he started to improve and started walking, but during walk he felt misbeats as well as evidence in his smartwatch. So he again contacted the hospital, and where they did a Holter 24 hours Holter monitoring, having 12,000 ectopics, which is very serious for systemic sclerosis because it is related to sudden cardiac death. So cardiology was initially cardiology was involved. They were reluctant to do a primary ICD, but it was done and he's doing fine. Another case, the last one, case from rheumatology department, Sjögren Hospital. She was a 63-year-old female having a Raynaud's phenomena, shortness of breath, skin tightening proximal to metacarpopharyngeal joints with arthritis of the small joints. Her serology was also positive, and HRCT showed an ILD with a UIP pattern, and her echo and ECG was normal. She was treated with steroids and mycophenolate, but she didn't improve in 6 months' time, both with her respiratory clinical capacity and HRCT findings. Rather, she developed now ground glass appearance further worsening as well as honeycombing. She was planned with cyclophosphamide, NIH protocol. Still, she was progressing. Then in 2021, ACR approved interleukin 6 inhibitor for interstitial lung disease, and she was started and again given for 6 months. And later on, she was put on mycophenolate, and she is still stable and doing good radiologically and clinically. In systemic sclerosis, what recommendation is there? Recommendation is there in Raynaud's phenomena and digital ulcer disease. Raynaud's phenomena and its complication are two different entities. And for Raynaud's phenomena, we all know that nifedipine calcium channel blockers, if they control it, we observe it, but if we do not control, we always add phosphodiesterase inhibitor. But for digital ulcers, for its healing, we add prostacyclin agonists. And with that, if we want to avoid new digital ulcers, we add again endothelin receptor antagonists and phosphodiesterase inhibitors. For interstitial lung disease, what recommendations have been set is for patients who are not on immunosuppressive treatment, we have to consider mycophenolate or rituximab or cyclophosphamide. And if after 6 months there is settled progression, then we continue with the same, either one of the treatment, but it is progressive, then the nintedanib has been recommended, a tyrosine kinase inhibitor, antifibrotic agent, either with mycophenolate or without it. And with 6 months, we follow up. If it again progresses, we go to rituximab, B-cell therapies. For pulmonary artery hypertension, we have either patient without treatment or already taking treatment of double vasodilators, phosphodiesterase inhibitors, or bosentan for digital ulcers. And what we do it, we upfront add the combination. If the combination leads to a good functional class, we continue the treatment, or if it doesn't, then we go to the other modalities like riociguat, which has been used recently and seen to be, it is basically a GMP stimulator, increase vasodilation of the vasculature of the lungs. And if it does, then with prostacyclin agonists, we add continuous IV prostacyclins to save the worsening. So these are the 8 domains which come into these recommendations, and we have discussed few of them, but for joints we are going to discuss later. Methotrexate has been shown to improve skin problem, as well as, if we can see the cut, PPIs, prokinetics, and antibiotics for lower GI. And for renal crisis, scleroderma renal crisis, no ACE inhibitors for prophylaxis. Rather, it has been seen that the prophylactic giving ACE inhibitors causes a decreased response during renal crisis when given with ACE inhibitors. So, current treatments focus on managing individual organ manifestation, which target inflammation, fibrosis, and vascular dysfunction, and they do not address the underlying disease. And a true disease-modifying drug has been missing, which is the critical gap. While coming to the new era, the predictive biomarkers of pulmonary artery hypertension and scleroderma renal crisis, anti-ETAR and anti-A1R microRNAs which circulate in the blood, might be one day like we started to have anti-CCP antibodies in early 2000s. These biomarkers also come into play with scleroderma. And in addition, adding a nail fold capillary evidence of vascular damage, we can predict and plan early individualized treatment strategies. Now, Dr. Uzma has discussed CAR T19 therapy. I would like to elaborate in 1 to 2 slides what it is. But it has been seen in scleroderma that it has demonstrated 100% post 6 months probability of improvement of ACR CRISS score, and suggesting a complete resolution of the disease. The Rodnan score also decreased to 13% in the first 33 months, and HRCT also yield reduction in progression of the disease. So how it emerged as a therapy? It has been seen that rituximab has depleted B cells in the therapies, but it was not persistent. After 6 months, it repopulates, and again we have to give it. Seeing the effect of the depletion with an improved outcome of the disease during that time, it was a need and thought that a persistent suppression is required. So that area with rituximab on the shoulders of rituximab, it was being tried, and it has a very promising results. And it also been used in disease phenotypes which were aggressive to prevent irreversible fibrosis and organ dysfunction. But it was not without risk. It's been studied nowadays. The cytokine release syndrome and long-term effects are yet to be identified. It has been used for cancer therapy, lymphomas, and a genetically engineered patient's own T cell to target and destroy cancer cells expressing CD19. How they do it? They take the cells from the blood, modifying them to express a chimeric antigen receptor which bind to CD19, and they inject it into the blood, and that fight cancer. And the same way they fight the antibodies, CD8 driven antibodies. Another is the bispecific antibodies, promising immunotherapeutic strategy simultaneously targeting two disease pathways, and they are CD3, CD19, and CD3, CD20. And it inhibits the fibrinogen activating protein and reduce fibrosis. So these are the emerging therapies. I'm not going to detail of each, but again, anifrolumab used in SLE being tried in the phase 2b trial of systemic sclerosis. Again, a B cell stimulator inhibitor, melanocortin receptor modulations, FcRn has been discussed, then phosphodiesterase 4b inhibitor, and then Avansugard GCMP cyclase activation. So future research is to identify more predictive and precise markers of which specific end organs are going to be involved in systemic sclerosis. And refining treatment protocols are necessary to enhance safety and efficacy. And interestingly, that is the triumph. Era of precision of medicine in systemic sclerosis not even has emerged, but it's in our clinical practice now. These are the priority pathways which are planned to be discussed in the next clinical trials: regulatory T cell enhancements, connective tissue growth factor, FcRn again. And this is, I want to discuss the immune fibrotic synergy, mycophenolate, rituximab, and nintedanib at the same time. This is also been planned to be studied. Then biomarker-driven strategies at research. In Europe, there is a progression correlated with these markers, antibodies KL6, SPD, and CCL18 with fibrosis and progression of interstitial lung disease, for digital ulcer and pulmonary hypertension. It is CXCL4 and endostatin, as well as the biopsy findings and finding out gene expression signatures also gives us a strategy and understanding that which specific biologic is going to have a good effect. So management of skin manifestations, this is a timeline and the triumph that specific treatments are emerging. In the 2023 guidelines, recommendation A is methotrexate. Initially it was being in trial in 1996, but it was not so much seen to be beneficial. But in 2011, it has shown a good response. So it is a recommendation A for systemic sclerosis, skin diseases. Cyclophosphamide, though it has been used in interstitial lung disease, and the arm which saw that the skin was also being improved with it, and but to date it was not been recommended to give it primarily in skin disease. Then comes tocilizumab. It is a level D recommendation. For skin manifestation, it also has a minimal effect. Likewise, mycophenolate, a recommendation B, and rituximab in a DESIRES trial in 2018 has shown remarkable improvement in reducing skin fibrosis. Likewise, interstitial lung disease. We started in 2006 with scleroderma lung study 1, and they recommended cyclophosphamide as has been included as a recommendation in 2023. Likewise, tocilizumab, it was being approved by FDA in 2021. And that is why after that approval, we have started the patient we treated at Sjögren with tocilizumab for her interstitial lung disease for 6 months. Then mycophenolate, a recommendation A. Then rituximab, again a recommendation A. And in 2023, Recital trial compared cyclophosphamide with rituximab, and they have comparable results of improvement, though rituximab had a better safety profile as compared to
2 minutes more.
rituximab. So management, pulmonary hypertension, I have discussed that dual, we have endothelin receptor antagonist, phosphodiesterase inhibitor, as well as combination therapy in severe cases. Then this GMP stimulator improves hemodynamics, and we know that we have prostacyclin agonists, and they are either IV or subcutaneous. Selexipag is an oral selective prostacyclin receptor agonist and is coming to the market soon. Then this is sotatercept, first line in class of active signaling modulator, significant improvement in pulmonary vascular resistance. And the European Respiratory Society and Cardiac Society has recommended a combination of ERAs and phosphodiesterase inhibitors in interstitial lung disease and prostacyclin agonists and GMP stimulators for refractory cases.
1 minute more.
Okay, I will be fast. So, emerging therapies are botulinum toxin for Raynaud's phenomena and digital ulcers and fat grafting, and for systemic sclerosis, renal crisis. ACE, I have said that it is contraindicated. Iloprost showed a reducing in renal artery resistance, 30% of the patients requiring long-term, and rest of them may gain normal renal function, but it is a time-consuming process, up to 2 years even. For GI, upper GI, we know that these all are used and recommended. Small intestine, we have now rifaximin, IVIGs, and fecal microbiota transplantation. Do read about it. For management of musculoskeletal, though recommendation is of methotrexate, but anti-TNF, IVIGs, and JAK inhibitors, they do not have a clear effect, but the new venues are the co-stimulatory molecules and interleukin-6 again. So early intervention, individualized treatment approach, as well as it has been seen that non-Raynaud's symptoms emergence before that, MMF was given, it has reduced the decline of FVC compared to those treated later, as well as tocilizumab has the same response. And early ERAs, endothelin receptors, antagonists have been shown to improve the outcome of the pulmonary hypertension as well. Non-pharmacological therapies, research programs, patient education in our setup is very much important, and smoking cessation and personalized preventive approach is essential. Future research is to identify further early biomarkers and new treatment modalities. So in summary, once an orphan disease has come out of deep water dynamically, to date, the latest recommendation is a triumph. Emerging therapies and biomarkers demonstrated encouraging results to even reaching remission. And non-pharmacological therapies are also essential. So this is my unit at Sjögren Hospital, where we work and do our research, and we have just in the last Monday, we have carried out a World Arthritis Day with a walk as well as a symposium This is my team, this is my new senior registrar, and these are my residents. So thank you very much.
Thank you, Dr. Aflak, for such an insightful talk. Our next distinguished speaker is Dr. Taqdees Khaliq, consultant rheumatologist at the Federal Government Polyclinic Hospital, Islamabad, Pakistan. Dr. Khaliq is a committed clinician whose work reflects a deep dedication to advancing patient care and promoting evidence-based rheumatology practice. Today, Dr. Khaliq will be speaking on systemic lupus erythematosus, new EULAR ACR guidelines and trials. Please join us in welcoming Dr. Taqdees Khaliq.
Bismillahirrahmanirrahim. Assalamu alaikum. It is indeed an honor to be present here and among the luminaries of rheumatology and share my bit of knowledge. My heartfelt congratulations to the organizers for putting up such a brilliant scientific conference. The focus of my talk today is the latest ACR and EULAR guidelines on lupus and the clinical trials that are redefining the way we treat this formidable disease. These are my disclosures. So lupus, as we know, is a disease with 1,000 faces, which means that no two patients of lupus are ever alike. And even in a single patient, we can come across diverse clinical manifestations, and that can make it difficult for the physicians to make a sound treatment plan for the patient. And in situations like this, the clinical practice guidelines come into action and help us navigate the complexities of the disease, and at the same time ensuring the clarity and consistency of our clinical decisions. Over the years, both ACR and EULAR have updated their recommendations to reflect the growing body of evidence and the latest therapeutic options that are available. And the latest guidelines are no exception. I'm going to walk you through these guidelines and highlight the key differences from the previous guidelines. I've tried to make a very short presentation, which is very to the point and crisp, so that the junior faculty members can easily understand the concept. So the first thing that both the guidelines suggest is a prompt diagnosis of lupus. So after ruling out all the lupus mimics, and we know that there are lots of lupus mimics, we are supposed to make the diagnosis of lupus promptly without any delay, because any delay in the diagnosis can result in poorer outcomes for the patient. Now, once the diagnosis has been made, the next step is to stratify the disease into mild, moderate, and severe categories, because our treatment decision will be based on the category, on the severity of the disease. And after this, we are supposed to integrate a treat-to-target approach earlier on in the disease concept, in the disease course. Now, the concept of treat-to-target in lupus primarily focuses on two achievable goals. Number one is remission, and if that is not possible, then number two is to attain a state of low lupus disease activity. This concept was first introduced in 2019 EULAR guidelines and has been retained in the current guidelines as well. However, in the 2023 guidelines, the overall philosophy of this concept has not changed much, but the targets have become more defined and more stringent, as we shall see in the subsequent slides. So in EULAR 2019, there was no universally accepted definition of remission, and the guidelines therefore referred to remission in a more general sense. Whereas in EULAR 2023 guidelines, there is introduction of validated DORIS criteria of remission. I'll be going through this criteria in detail in a while. Also in the 2019 guidelines, long-term maintenance prednisolone dose was accepted at 7.5 milligrams or less, and with the goal to completely withdraw them as soon as possible. Whereas in the latest guidelines, the prednisolone dose has been further reduced to 5, the acceptable prednisolone dose has been further reduced to 5 milligram per day, or even lower than that, in order for a person to have remission or lupus low disease activity state. Now, this is the DORIS criteria that has been introduced in the 2023 guidelines. This criteria consists of 4 components. Number 1 is the clinical SLEDAI, and this should be 0. This means that clinically, patient should have quiet lupus. There should be no lupus activity. Serological activity, however, is allowed, which means that the patient can still have positive anti-DS DNA, they can still have low complement level. As long as clinically they are stable, they'll fulfill the first criteria for remission. The second component is SLEDAI PGA score of 0.5 or less on a scale of 0 to 3. So anything more than that will not satisfy this criteria. Then we talked about glucocorticoid maintenance dose, and this, according to this criteria, it should be 5 milligrams per day or less. And lastly, the patients are allowed to be on stable doses of immunosuppressants, including HCQ. If this is the first target, remission. If this cannot be achieved, then the second acceptable target is to attain a lupus low disease activity state. And here, the first component is SLEDAI 2K score of 4 or less. And here, the important thing to note is that there should be no activity in any major organ system of the body. And again, serological activity is allowed as long as total SLEDAI 2K is 4 or less than 4. The second component is SLEDAI PGA, and it should be 1 or less than 1 on a scale of 0 to 3. And the third component is prednisolone dose, the maintenance prednisolone dose. And here, like I mentioned in the earlier slide, the dose has been reduced further to 5.5 milligrams per day or less. And the last component is standard maintenance doses of immunosuppressive drugs and approved biological agents, excluding investigational drugs. So once we are clear about the treat to target approach, we then embark on the actual treatment of the patient and choose our drugs. So the first drug that all the patients require is hydroxychloroquine. And this is a well-established fact. This drug is the backbone drug for all the SLE patients, and it is recommended for everyone with SLE unless it is contraindicated. Here's a difference in the current guidelines. Both ACR and EULAR has now decreased the dose to strictly 5 mg per kg real body weight per day, because if the doses are increased, if the higher doses are given, then the risk of retinal toxicity increases. However, both guidelines have allowed short courses of higher doses between 5 and 6.5 milligrams per kg per day at initiation of treatment, or to maintain disease control for a brief period of time. So after putting every patient on HCQ, we then have to decide whether the patient requires glucocorticoids or not. And here is a key paradigm shift. The latest guidelines view glucocorticoids as a bridging therapy only. So this therapy is to be used during periods of active disease to quickly control inflammation. And there is a strong recommendation for rapid tapering to 5 milligram or less than 5 milligram equivalent per day, with ultimate goal of complete withdrawal of glucocorticoids as soon as possible. The pulse steroid therapy has been reserved only for organ-threatening or life-threatening situations. And this is quite different from what we have been studying initially. So after steroids, we then decide whether our patient requires any immunosuppressant therapy, long-term immunosuppressant therapy or not. And for this, there are guidelines issued both by ACR and EULAR. So any patient who's not responding to hydroxychloroquine alone or in combination with steroids is a candidate for long-term immunosuppressant therapy, typically given for 3 to 5 years. And secondly, in patients who are unable to reduce their glucocorticoid doses below the acceptable range are also a candidate for long-term immunosuppressant therapy. Now, the key change here is the introduction of biological drugs in SLE. This is a notable shift from the previous recommendations. The current guidelines integrate biological agents at par with the conventional immunosuppressant drugs, MMF, methotrexate, azathioprine, and they are now considered equivalent therapeutic options for prompt initiation to control disease activity and facilitate the reduction of glucocorticoid use. So this is how the algorithm looks like now. HCQ, steroid, the conventional, I'm sorry, this is not working. The conventional immunosuppressant drugs, methotrexate, azathioprine, mycophenolate, mofetil, and then the newer drugs, belimumab and anifrolumab, which are the biological agents, and their recommendation is stronger than what it is for the conventional drugs. And we can also see that CNIs and cyclophosphamide and rituximab are reserved for the refractory or very life-threatening situations. So a brief discussion on biologics in SLE. The first biologic to be tried in SLE was rituximab. The two famous trials, LUNAR and EXPLORER trials, they could not achieve the required endpoints, and that is why it could not gain the FDA approval for management of SLE. However, it has been used consistently based on evidence-based medicine. A year later, we saw the emergence of belimumab, which is the first ever biologic drug which has been used for the management of SLE. And it was shown to be beneficial in non-renal lupus, and the clinical trials that showed us its efficacy were BLISS 52 and BLISS 76 trials, and we are all familiar with those trials. Then there was a hiatus of a couple of years before belimumab was found to be useful in renal lupus as well. And the evidence for this benefit came from the BLISS LN study, which I'm going to discuss briefly in a while. And this happened in the year 2020. It gained FDA approval. A year later, we saw another biological drug being approved for the management of SLE by the name of anifrolumab, which is a type 1 interferon inhibitor, and it was also found to be beneficial in non-renal lupus. Since then, there have been a couple of trials in patients with lupus nephritis as well, as I shall mention in a while. And lastly, obinutuzumab. This is the newer anti-CD20 drug, which has shown benefit in lupus nephritis, and as of yesterday, it has been included in the EULAR 2025 lupus nephritis guidelines. So this is another milestone achieved, and another potent drug has been included in our armamentarium against SLE. So the guidelines have given us recommendations regarding treatment of different manifestations of SLE, like mucocutaneous SLE, cerebritis, joint disease, etc. But I'll focus only on the treatment of active lupus nephritis, because here again we see a key paradigm shift. Both the guidelines now suggest combination and continuous therapy targeting multiple pathogenic pathways simultaneously in order for a better disease control. So initial high dose of IV methylprednisolone in pulsed form is given for 3 days, and this is followed by oral prednisolone with a rapid oral taper. And simultaneously, patient is put on triple therapy, in which patient is given hydroxychloroquine, glucocorticoids, along with immunosuppressants. And on top of that immunosuppressant, either cyclophosphamide or mycophenolate mofetil, either a biologic drug, which in this case would be belimumab or obinutuzumab, or a CNI inhibitor like tacrolimus, or voclosporin is favored for new onset of active or flaring proliferative lupus nephritis, whether it is class 3, 4, with or without class 5. And the duration of therapy typically is 3 to 5 years. So the paradigm shift is that while previously we were aiming for an induction phase and then a maintenance phase, we now aim for early combination therapy, and it is then given as a continuous therapy. So a brief mention of the recent advances and key clinical trials in lupus that have redefined the way we look at lupus. This is a very beautiful diagram which gives us a very nice overview of the key clinical trials. So the first trial that I mentioned, BLISS-LN, this concluded in December 2020, and it showed favorable results of belimumab for lupus nephritis patients when it was given in combination with standard of care, and this led to the approval of the drug by FDA for the management of lupus nephritis. Then we can see Aurora 1 and Aurora 2 trials, which were performed on voclosporin to test its efficacy in cases of lupus nephritis. And again, it showed very encouraging, promising results, and hence it gained approval for adults with active lupus nephritis in the year 2021. Then we have TULIP-LN1 trial. Now this is different from the TULIP-1 and TULIP-2 trials of anifrolumab. Those two trials did not recruit any patients with active lupus. However, TULIP-LN1 trial, it was a phase 2 RCT. It was performed on patients who had active nephritis. The trial failed to meet the primary endpoint. However, there was significant difference along different variables, and this then led to the initiation of another phase 3 trial of anifrolumab by the name of IRIS trial. And this trial has just been concluded, and it has shown very promising results, establishing the role of anifrolumab in lupus nephritis management. So here we see Nobility and Regency trials. These were performed on obinutuzumab, and these were the key trials that led to the approval of obinutuzumab for the management of lupus nephritis by the EULAR. And then we have Calibrate and Symbiose 2 studies, which are a proof of concept studies performed on very small number of patients. Here, sequential therapy with rituximab and belimumab has been tried. So far, the results are very encouraging, and there's a hope that in future a combination will also be advocated. So as far as future research in lupus is concerned, Calibrate and Symbiose study that I just mentioned, this is a proof of concept study in which combined rituximab and belimumab are being used for treatment of SLE patients with severe refractory disease.
So 3 minutes to go. 3 minutes.
Okay. And to investigate the long-term immunological and clinical effects of this combination in severe refractory SLE patients. And the initial results are quite encouraging. Next, we have Reset SLE trial, which is being performed on CAR T-cell therapy. Dr. Uzma and Dr. Aflak both mentioned CAR T-cell therapy in their talks. This is a new and emerging therapy. And the results of this therapy also were very encouraging. Data from SLE and lupus nephritis patients infused with RECELL showed early clinical response, including meeting the DORIS remission criteria and complete renal response, and an acceptable safety profile in the setting of CAR T-cell expansion and peripheral B-cell reduction. The only concern is the emergence of some serious side effects like cytokine release syndrome. They are being looked into, and so far the safety profile is acceptable. Moreover, new trials on deucravacitinib are being done. This is a tyrosine 2 kinase inhibitor, tyrosine kinase 2 inhibitor, and the initial phase 2 study showed patients who received this drug were more likely to achieve an SRI-4, and all the secondary endpoints were also met. And lastly, efficacy and safety of upadacitinib and elsubrutinib, which is a Bruton's tyrosine kinase inhibitor, and inhibits B-cell activation, thereby halting the cascade of inflammation in SLE. These trials are also taking place either in upadacitinib being used alone or in combination with elsubrutinib. Initial results are quite promising, and the full results will be available by 2026. So that's all about the latest lupus management guidelines and the clinical trials. Thank you very much for your patient listening.
Thank you for the compelling presentation, Dr. Taqdees. We are delighted to welcome Dr. Parveen Saber, consultant rheumatologist with the National Health Service, United Kingdom. Dr. Saber brings with her a wealth of international clinical experience and a strong commitment to advancing the understanding and management of autoimmune diseases. Her talk titled Unraveling Primary Sjögren Syndrome, Advances in Diagnosis and Management focuses on one of the more intricate and often under-recognized autoimmune disorders. Ladies and gentlemen, please join me in warmly welcoming Dr. Parveen Saber.
Assalamu alaikum wa rahmatullah. Right, so we're going to speak about Sjögren's disease and what's new. So the first thing that's new is I've actually changed the topic heading. As you can see, as of June 2025, Sjögren's is no longer a syndrome, but rather a disease. And this was announced at EULAR 2025. So we're going to talk about what's new in guidelines, pathophysiology, and then treatment options. Some of these have already been mentioned by my esteemed speakers. So what's new in guidelines? So we still confirm diagnosis the same way for both adults and children using the 2016 EULAR ACR criteria. We need at least 4 scores, and you need presence of Rho and La antibodies, which gives you a number of 3. You need a focus score of 1 or higher. A focus means that when you do a biopsy from a salivary gland tissue, there are at least 50 lymphocytes per 4 millimeter square area surrounding a ductor and acinus. There needs to be abnormal ocular staining scoring, which scores you 1, and this is used using fluorescein for cornea and conjunctival lissamine green for conjunctiva, sorry. You use Schirmer's test, which you've probably used, and unstimulated salivary flow, which needs to be less than 0.1 ml per minute, where a patient is asked to empty their mouth and then drool into a funnel for about 5 minutes. Once you confirm the diagnosis, you do a lip biopsy. This can give you a sensitivity of 75% and specificity of 85%. You can do an ultrasound. You check for comorbidities. Of course, we do a clinical examination, urine dipstick for lipoprotein, etc. Do other blood tests, full blood count, liver, kidneys, and then specifically immunoglobulin, C3, C4, thyroid function to look for other autoimmune diseases as well, as a test shown here. To note that low C4 is the strongest predictor for future lymphoma as a complication. So we treat dry eyes, mouth, systemic dryness, and other systemic involvement is also treated. For the eyes, you check tear breakup time using a slit lamp, where if it's more than 9 seconds, the dryness is mild. 5 to 9 seconds is moderate, and less than 5 seconds tear breakup is severe eye dryness. You use varying degrees of strengths of tear replacement, anti-inflammatory drops. Both upper and lower puncta can be plugged to conserve the tears. You can permanently cauterize tear ducts, use serum drops, meibomian gland therapies, and scleral contact lenses can be inserted. Self-help, patients can use artificial tears over the counter. Omega-3, apparently 2,000 milligrams, can stabilize the tear film. Eyelid hygiene using cleansing wipes will improve oil flow and remove dead skin. Warm compress for 10 minutes can actually help the eyes as well. And using humidifier, especially in the winter time, keeping humidity at 40 to 45% will help. Overnight care with gels and ointments, again, humidifier and eye masks, etc., can seal the moisture in the eyes. You can use these varying degrees of strengths of eye drops, depending on the severity, and you can use something at night time as well. For dry mouth, there are a number of gels They don't always work. And often, in my experience in Pakistan as well as abroad, sometimes, most of the time, they're not available. Drugs can be used, such as pilocarpine 5 milligrams 4 times a day, cevimeline 3 times a day, bethanechol 3 times a day, high fluoride toothpaste, which has to be specially prescribed by a dentist, and we recommend twice a year dental review. The patient can massage the glands, chew on non-sugar containing gum, sucking on a hard object can help. Sprays and gels or rinses can be used, oil pulling with extra virgin coconut oil, and looking after the teeth using things such as baking soda and 5 ml per liter to rinse the mouth. And also, it's recommended if a patient thinks of lemons, that can also induce a little bit of saliva flow. Extra articular manifestations are many. These include musculoskeletal, dermatological, neurological, renal, hematological, pulmonary, and non-Hodgkin's lymphoma, which is the most serious. You treat them appropriately as per guidelines. And at breakfast, I was talking to Dr. Taqdees this morning, and she was saying we are actually seeing more and more complex Sjögren's disease now. For musculoskeletal, pain occurs in 96%, myalgia in 70%, and actual arthritis, inflammatory arthritis, occurs in 16%, which is treated as per guidelines for rheumatoid arthritis. Neurological symptoms can be mild cognitive dysfunction to quite severe. There can be demyelinating disease, such as neuromyelitis optica, lymphocytic meningitis, or cerebral vasculitis. There can be cranial neuropathies, and peripheral nervous system can be involved in up to 16%. These can be sensory and sensory neuropathies, small fiber neuropathy, and autonomic dysfunction as well. Dermatological conditions occur in about 72%. Most common are dry skin, dry eyelids, Raynaud's phenomenon, and less often cutaneous vasculitis, amyloidosis, or annular erythema. There can be renal issues. These are relatively less common in about 5% of patients, and most commonly involve tubulointerstitial nephritis, distal renal tubular acidosis, and membranoproliferative glomerulitis, which is less common. Hematological include cytopenias, hyper and hypogammaglobulinemia, hyper being more common. There can be monoclonal gammopathy. Cryoglobulins occur quite often. There can be leukopenias, anemias, and thrombocytopenia, of which thrombocytopenia is most common. Lung involvement can be 9 to 75% according to different studies that you look at. It can include cough and shortness of breath due to dryness, bronchiectasis and bronchiolitis, interstitial lung disease of various types, cystic lung disease, and pulmonary hypertension. If a patient is planning a pregnancy, counsel them for neonatal lupus, because often these patients have Rho antibodies positive, and you counsel them against congenital heart block. Aspirin can be given from 12 weeks and may reduce their risk of preeclampsia, and hydroxychloroquine in Rho positive individuals may reduce their risk of congenital heart block to a degree. We treat comorbidities appropriately, and also early diagnosis and treatment of lymphoma is crucial, where there is salivary gland enlargement, lymphadenopathy, Raynaud's, anti-Rho and La antibodies, rheumatoid factor positivity, monoclonal gammopathy, and C4 hypocomplementemia, which can be checked in the start. Non-Hodgkin's lymphoma is one of the scariest complications in Sjögren's. According to a 2024 meta-analysis, it's 8.7-fold increased risk in patients with Sjögren's. The highest occurs at age 40 to 49, and more often in females, and low C4 is the strongest predictor. So, coming to what is new in pathophysiology. So we know, we have learned more about pathophysiology recently. We know that in genetically susceptible individuals, viral infection, possible viral infection, can trigger salivary glands, and this activates both innate and adaptive immune system. The activated salivary glands will then produce cytokines that you can see here, and these include type 1 interferons, IL-6, B-cell activating factor BAF, and CXCL12. Sjögren's has a strong link to B-cell hyperactivity and differentiation, thus causing hypergammaglobulinemia with high BAF levels and thus associated with lymphoma. And the damaged epithelial cells are perpetuated by CD8 T cells, causing chronic release of autoantigens, stimulating the innate immunity in a vicious circle. CD4 and especially T helper cells cause formation of germinal centers. So, along with B cells, these produce high affinity, causing immunoglobulin class switching. B cells, natural killer cells, monocytes, macrophages, and Th17 cells participate in the development of the disease. Interferons are quite important here. The damaged epithelial cells release autoantigens, stimulate this, and therefore the disease will progress. Sjögren's is considered to be an autoimmune epithelialitis. So the epithelial cells are the target as well as an active player in the disease. So what's new in our understanding of epithelial cells? We know that we had a 2D model of the epithelial cells which lacked ability to fully assess the function of how it secretes. And this 3D model was first developed by Pringle. This allows confirmation of specific abnormalities, such as premature aging and salivary gland stem cells with senescence and block differentiation into acinar cells were found. We developed organoids, which are like fake little organs. These were developed from salivary gland biopsy from patients as well as controls. The ones above are control, and the ones below in all of these are from the Sjögren's patients. These express ductal and epithelial SNR markers and has the architecture of a glandular biopsy. The main thing we noticed was that in Sjögren's myopsy, there is non-normal morphology with a lack of branching. So this is the patient, so normally they do branch, and in patients they do not branch. So when the organoid is stimulated with double-stranded RNA, causes production of cytokines, BAF, APRIL, and interferon type 1 and 3. Interferon signaling is a main characteristic of Sjögren's, and while we haven't found the exogenous trigger, such as a virus, endogenous triggers like DNA and RNA can lead to type 1 interferon production. Keeping in mind that the key autoantibody in Sjögren's is an anti-SSA against Rho60, and only a few months ago we found an accumulation of mitochondrial RNA in saliva and tears, which correlates with the interferon signature. So if we increase the double-stranded RNA, we may activate the interferon pathway, and if we block it, we can reduce the interferon signaling. So maybe double-stranded RNA in epithelial, exogenous, or endogenous cells can alter the outcomes. So new mechanism of regulation of RNA were found. We understand that if DNA is methylated, it downregulates its function, whereas when RNA is methylated, it controls which protein will be produced. This is called translation. So in Sjögren's, methylation can be controlled, and thus it can be manipulated to change treatment. So, coming to what's new in treatment. So we have a large number of drugs which are currently in phase 2 and phase 3 trials. And out of these, I'm going to mainly just focus on the ones in phase 3 because there's a large number of them. Interesting to note, currently there are studies that suggest that perhaps a combination of leflunomide with HCQ and mycophenolate with HCQ might actually help. above using them individually. So, we're not going to talk about this, although this is implicated in most things nowadays, but there is some anecdotal evidence that Ozempic can possibly help Sjögren symptoms and reduce ANA and DNA. However, some patients report that it increases oral dryness. So, what's hot and new is, as of October 2025, this drug, nipocalimab, has actually been FDA approved to use in Sjögren's disease. This is a monoclonal antibody that binds with high affinity to the anti-neonatal Fc receptor that Dr. Shazi also talked about, and reduces the circulating immunoglobulin G. This doesn't affect the other immune functions of IgG. And in Sjögren's, there are specific autoantibodies and lymphocyte infiltration that it can help prevent side effects from. Another drug, which has had 2 successful phase 3 trials, so far has been used in Sjögren's, ITP, SLE, warm autoimmune hemolytic anemia, as well as diffuse cutaneous systemic sclerosis. It depletes B cells and blocks BAFF receptors, and it can improve salivary flow, patient outcomes. Steroid use, its mechanism of action is mentioned. Then the next drug is telitacicept, which binds to and neutralizes the activity of 2 cell signaling molecules, BLIS and APRIL, as shown here. So these 2 are blocked, and this will suppress the development and survival of plasma cells and mature B cells. When this was used, it reduced IgA, IgM, C3, C4, as well as B cell counts. And 72% patients receiving this drug at 160 milligrams achieved SDI reduction of more than 3 points at 24 weeks, compared to 19% in case of the placebo. Dazodalibep is a drug which is again in phase 3 trials, currently ongoing. It's a non-antibody biologic antagonist of the CD40 ligand. Further drugs which were also mentioned by my esteemed colleagues are efgartigimod, which is again a neonatal Fc receptor antagonist. It outcompetes the endogenous immunoglobulin G and prevents pathogenic effects of IgG.
Yeah, 3 minutes left.
Okay. Deucravacitinib is an oral tyrosine kinase inhibitor, part of the JAK kinase family. Again, it blocks the tyrosine kinase 2 in an inactive state, preventing its activation by cytokine receptors.
Much. If any one of you have got questions, ushers are around you. You can ask for the cards and write down the question for the speakers. Thank you so much. All talks were very enlightening, and we are waiting for the questions.
So wonderful speakers from abroad and from Pakistan in the review course session. They have highlighted all the updates, and but naturally we have some limitations of the availability of drugs. Just wanted to ask if there is any role of stem cell therapies in the refractory state of such diseases when we have tried all options. Is there any role of stem cell therapy in the refractory state of Sjögren's?
Yes, absolutely. It has a very promising effect, but currently the CAR-T19 is being in the limelight, but autologous human stem cell therapy is being researched nowadays, and it also gives a very promising results. Rather, I would ask that I heard that CAR-T19 therapy has been done in AFIP. Do you have that any insight to it? And what were the results?
Yeah, in Army we are doing a trial of 100 patients. They are in the refractory autoimmune diseases. So it's a stem cell therapy, and it's a double-blind trial, first of its kind, I think, in the country. So expectedly the results would be out in next 3 to 4 months. But regarding CAR T cell therapies, we have the facilities available, but we are going to start shortly.
Okay, I was talking about some lymphoma treatment regarding CAR-T19 therapy at CMH.
Another question for Dr. Aflak, asked by Dr. Saira. She's a PG trainee in Fauji Foundation Hospital. She wants to ask, please comment on the combination of sildenafil and bosentan in treating pulmonary arterial hypertension and systemic sclerosis.
Yes, first of all, I've just elaborated in my talk that digital ulcers has a very recommendation has been there regarding giving a dual therapy, and by giving these dual therapies, it also prevents progression of pulmonary artery hypertension. So in pulmonary hypertension, these both of them are recommended now in the updates of the EULAR recommendations regarding systemic sclerosis.
Thank you. So the next question and the last question is from Dr. Tajvur. Dr. Aisha has asked you that can targeting the interferon pathway changes the current management landscape for primary Sjögren's?
Yes, it seems so. There are some phase 2 and phase 3 trials ongoing. I think the first couple of drugs are about to be approved in Sjögren's. They haven't been, but there have been trials that have shown improvement, yes.
Thank you very much. So with this, we conclude the session, and I think she has got an announcement for you.
Thank you to our speakers.
And last, one question, please, to Madam Tajvur. Kindly, Madam, tell us about the recurrent RTA when we give the immunosuppressants, and if, like mycophenolate doesn't work, what should be the options next? Okay.
Okay, I'll let you know. If you email me, I'll have to look it up actually.
Okay, thank you.
Okay. So thank you to our speakers and audience for such a thoughtful exchange. Now I would request the worthy chairs, Dr. Tahira Parveen, Brigadier Professor Amir Fakhr, and Dr. Ataur Rahman to present a token of appreciation to our speakers. I would request our speakers to also please come on stage. Professor Uzma Rasheed. We just request you all to come on stage. Thank you. Next we have Dr. Aflak Rasheed. Do we have Dr. Aflak here? Okay. Next we have Dr. Taqdees Khaliq. And last but not the least, Dr. Tajvur Parveen Saber. Now we would like to request Professor Nigat Mir Ahmed, Patron and Chief, and Professor Ahmed Said, President and Convener of PSR, to present a token of appreciation to the chairs of our session. Dr. Tahira Parveen. Professor Brigadier Amir Fakhr. Professor Brigadier Amir Fakhr. And Dr. Ataur Rahman. Thank you, everyone. मैं बोल दूं?